Uh, Now we move on to the management of subluxated lenses, soft, hard, and you name it. And there is no better person than Professor TITIYAL. Sir, thank you.
Yeah, thank you, Abhay. And again, good morning to all our friends today. And after listening to Subin and his instruction course in the morning, I think we are all now become expert in managing small pupil in a very, very difficult situations also. And one area which we again think is difficult is subluxated cataracts, because that really gives you a challenge, because entire surgical planning can get changed during the surgical planning as such. You're looking into various aspects of a subluxated lens. First thing comes to mind is what would be the etiology behind the subluxation. You are pretty safe if you have a history of trauma, because we know that entire general complex may not be degenerated or a disease. Therefore, surgery, whatever way we achieve, is going to last longer. The bag will retain its shape for a very, very long time. But you have a causes hereditary, where it is very difficult to manage the bag as such, or a comorbidity like hypermaturity, subsequent inflammation in the eye, or a pseudo-exfoliation. These are cases which are going to have, ultimately the bag may not be retained in a way we desire. And we have seen many, many cases after 10 years, 20 years, they all get dislocated in the vitreous cavities. Therefore, if we have a traumatic subluxation, it is non-progressive, and the surgery planning is simpler, and you can achieve various things. These are few important things that pre-op before we do surgery in these cases. We look after some of the important area which we know that should be taken care of, especially if there's a history of trauma. Do a good examination. Look for a proper lens position. If the granules cannot be seen clearly, then we may have to do UVM to see the entire granular capsular bag complex in these cases. Look for a degree of subluxation. Look for a condition of granules. Look for vitreous in the anterior chamber or in the angle areas. If possible, do a gonioscopy in these cases. Apart from that, the posterior segment assessment is very important in these cases of all cases of subluxation, because you may have a central macular pathology. There may be a macular hole. The visual analysis has to be done before surgery, and properly counsel has to be done. This is the algorithm we always talk about, what should be done, how much subluxation can be managed without the bag fixation. I consider anything less than 5 or 6 clock hours, you may be able to do a good phaco in these cases and fix the bag. If it is less than 3 clock hours, then simple CTR would be manageable in these cases. So today I'm going to talk about those cases where phaco can be done simply without you have to fix the bag, because that's a different scenario as if you have to bag has to be fixed by various devices. So these are various intraoperative problems which you can face in these cases. One of the most significant will be a bag getting dialyzed and nucleus getting dropped in the vitreous cavity. So that is what we're going to prevent in these cases. You see, this is a case, I think this is around 10-year-old video of mine. You can see around 4 clock hours subluxation here. The idea would be to stabilize the bag before actually we do a nucleotomy in these cases. The iris hooks or lens hooks both can be used here. Here I'm using iris hooks in an area where the subluxation was there. But these are area the granules were intact, and the rhexis has to be adequate size which can maintain the stress throughout. So subsequently, you can see here the nucleus rotation will be difficult. So I'm taking a piece of a nucleus so that there is a space created, and this space will allow the fluid to seep in and cause an internal hydro delineation, so the subsequent nucleus management can be done effectively. I think something has gone wrong here. So something, nucleus can be managed effectively in these cases. You can see here, this is the one job I'm initiating here. If you see carefully, this rotation is difficult at this area. So once you see this type happening, take out this piece, the nucleus will now get tumbled into central area, and rotation can be avoided. If you avoid the rotation, the stress to the granular complex is less, and you can maintain the integrity of remaining granules in a right manner and subsequently complete the surgery in these cases. Before you take out the handpiece, always fill the bag with the dispersive viscoelastic. That will maintain the bag integrity, will not allow sudden collapse of anterior chamber, which can further damage the granules. So this is a classical teaching for all cases where you have weak granules or a weak capsule. In these cases, you have to maintain. Always do a bimanual aspiration, especially these areas where subluxations are there, because the pieces or a tags is difficult to remove from that area. Little tangential movement will help you. The CTR has been put here. Subsequently, we'll implant the IOL in these cases. This is second option, which I consider one of the good indication for using a femtosecond laser in a case of a subluxation. This gives the advantage of doing 3 important steps before opening the anterior chamber. One is capsulotomy, which is done effectively in most cases. Then the incision is done without opening, and the nucleotomy. So 3 important aspects: the nuclear fragmentation, capsulotomy, and incision has been done before actually open. Because once you make an incision, the subluxation can increase and things can become very difficult in these cases. Just to give you one example of how we do a case with subluxation, because this is the area of subluxation which is around 3 to 4 clock hours. The lens is shifted. I'm shifting my capsulotomy towards the area of largest available capsule. So this is the area of area. You can see here, there's a vitreous in the anterior chamber also. Despite that, capsulotomy is achieved. Because of vitreous, you can see a gel formation of laser hitting the vitreous here. Subsequently, nucleus fragmentation done and incision will be done effectively. So that's the advantage of a system where you can use effectively. But if you don't have a femtosecond laser also, you can do effective tamponade of an anterior chamber with dispersive viscoelastic in an area where vitreous may be there or where the subluxation would be there, apart from putting the hooks here. Now I'm removing the capsule here. I've stained the anterior capsule so that if there's a tag also, that can be taken care of. And you can see after I remove that, I'll be putting my iris hooks, which are little posteriorly placed, so they are parallel to the iris plane. Inject triamcinolone, identify the vitreous volume, do a vitrectomy before you do a nucleus management in these cases. That is a very important aspect of managing subluxation here. So once I do a complete vitrectomy, I'll do because of laser delineation, I don't require to rotate the nucleus, and nucleotomy can be completed without any hitch here. So this is a very important aspect of taking care of a vitreous before actually doing a nucleotomy in these cases. Separation will allow the bubbles to come out, and this will allow the nucleus getting released from the capsular cushion which is there in these cases. Subsequently, each fragment can be taken out, and effectively it can be emulsified in the bag without compromising the peripheral general complex in these cases. I'm highlighting that because the bag fixation is very important. Sometimes you may have to insert the CTR before you do actually these procedure, depending on the amount of degree of subluxation in these cases. This is the rotation of a superior piece, and just pulling to a center, you can complete this entire emulsification effectively. The parameters has to be moderate. Bottle height is normally IOP of mine is 55. Here I put 46. Therefore, the management of subluxated case will be more effective in these cases rather than keeping the higher pressure in these cases and increasing the aspiration and vacuum in these cases. After I complete my nuclear emulsification, same procedure, I'll fill the bag with dispersive viscoelastic before I initiate the aspiration of cortex or taking out my handpiece subsequently. And this is going to safeguard the entire procedure. You can put CTR subsequently and implant the lens in these cases, as you saw in a previous case also. This is a post-op result of same patient, absolutely clear cornea, stable back and IOL in place and good vision. And the technique you can see in IGO video gallery, the entire technique is visible there. So I would summarize, if you have a subluxated cataract, especially traumatic variety, you can do a good phaco in these cases without fearing to increase the general damage in these cases. So any subluxation less than 5 clock hours, you can effectively do phaco, may not require a back fixation. Make sure that cases where you have a difficulty in the intraoperatively, back get dialyzed, rotation is difficult, nucleus is tilting, it's better to shift to a manual surgery in those cases than trying to do a complete phaco in these cases. Thank you, and these are a highlight of our post-op management, which is so important for all cases, more important for traumatic subluxated cases.
Thank you, Professor TITIYAL. This was a very difficult topic and a difficult scenario, but you made it very simple with a lot of clarity. So thank you so very much.